So if we could, all right, we're going to go ahead and get started. Thank you. How's it going so far? Pretty good, good. So this is an opportunity for us, and I'm really excited about this, is to talk about current and new treatment approaches. And so I have the pleasure of introducing Dr. Salwan, and she's an addiction medicine and internal medicine physician practicing in Montgomery Family and Internal Associates in Silver Spring, where she provides integrated primary care and substance use disorder treatment in addiction. I'm going to let her tell you a little more about herself, but this is an opportunity to learn. We heard that earlier today. I'm going to let her tell you about her work, some of the current and new treatment that is on our journey. Thank you, Dr.
Can everyone hear me all right? Usually I'm too short for microphones to reach my height, but this one works out pretty well. So thank you so much, Ken. Thank you to Health HIV for having me. It's an honor to be here today. I hope everyone had a nourishing lunch and is excited to talk about current and future treatment approaches. So again, my name is Jasleen Salwan. My name is pronounced like just lean on me. And a little bit about myself. So I work at Montgomery Family and Internal Medicine Associates in Silver Spring, Maryland. I am really deeply passionate about providing addiction medicine treatment in a primary care setting. I think it normalizes treatment for people who are facing addiction. And I think that the same way people go see their regular primary care doctor for an ear infection, they should be able to go see their regular primary care doctor to talk about the use of drugs or the use of alcohol and how to get help when they're facing addiction. So our model is such that we really believe in the longitudinal relationship between the patient and the primary care provider. So if we get a patient who already has a PCP, we encourage them to stay with that same PCP. Whereas if it's a patient who's been out of care, as is often the case when people are in the cycle of drug use, they fall out of addiction, they fall out of primary care. And now they need help with both the drug use piece and the general medicine piece. So we take ownership of both of those things. And we are taking new patients, and I do have cards, and feel free to connect with me afterwards. So that's a little bit about where I work, and then by way of disclosure, I also serve as a consultant for the District Addiction Consultation Service, and I'll tell all of you a little bit more about that service at the end. The views that I will express today are my own, though I'm certainly inspired by my expert colleagues at the District Addiction Consult Service. So our objectives for this session. First, we'll talk about what harm reduction means and what the vision for harm reduction looks like in the context of substance use disorder treatment. Then we'll talk about where we are now. What's the status quo in terms of providing treatment? And what limitations do we face that are preventing us from fully realizing the vision at this stage? And then finally, we'll look toward the future and talk about future directions for delivering patient-centered, empowering care. So what is harm reduction? So this definition comes from SAMHSA, the Substance Abuse and Mental Health Services Administration. Harm reduction is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other healthcare services. So we've heard this a lot today, right? Meeting people where they are. So we're talking about physically, geographically meeting people where they are, lowering the barriers to accessing treatment. And we're also talking about metaphorically or philosophically meeting people where they are. When people are still using drugs, they still deserve access to treatment to prevent adverse outcomes from their drug use. We don't want to wait until after somebody has already stopped using drugs before we offer services to them, because they may not survive to reach that point. A rallying cry in the harm reduction space of substance use disorder treatment is you can't recover if you're dead. So having defined harm reduction, let's talk about what the key components of harm reduction are. So one is, of course, syringe exchange, right? People who use drugs deserve access to sterile supplies so that they don't have to reuse needles or use needles with others. And of course, the end goal of this is to prevent the spread of diseases like HIV and hepatitis. Then there's overdose prevention. So we've talked a lot today about naloxone, or brand name Narcan, right? Narcan is absolutely critical. It's a life-saving opioid blocker and overdose reversal agent. And in addition, fentanyl test strips so that people using drugs may test their drug supply and determine whether or not it contains fentanyl. Nowadays, a lot of people are intentionally using fentanyl, and there also is a subset of the population of people who use drugs who is trying to stay away from fentanyl, who does not have any tolerance to fentanyl, and who can benefit from utilizing these test kits to have a better idea of whether or not they might be getting exposed to fentanyl from a particular drug supply, and who would avoid that drug supply if it tested positive for fentanyl. So these are a couple components of overdose prevention. I like to say, if a critic says that these are enabling people to use drugs, I would say it's enabling them to stay alive. They're already using drugs, and it's enabling them to survive the drugs that they have already decided they're going to use. So that's overdose prevention. Overdose prevention is something that has to be distributed in a really kind of structurally well thought out kind of way, because people cannot Narcan themselves, right? I had one patient tell me once, "I'm telling you, doc, I Narcan myself." Everybody was like, "How did you do that?" I was like, "Okay, all right, maybe." But in any case, one cannot reliably administer naloxone to reverse one's own overdose, right? If one has overdose, one is not conscious and cannot do that. And so we have to be able to structurally think about how to get the naloxone administered in a timely manner. And one of the ways to do that is to create safe spaces for people to use drugs that have trained personnel on site to administer the naloxone. So these are sometimes known as safe consumption sites. Supervised injection sites is another term, though a lot of us in the field are moving away from the word supervised because it may sound paternalistic and potentially turn people away. Overdose prevention sites is also a perfectly reasonable term to use, right? That's the goal of these sites, is to prevent overdoses. There are 2 currently operating on the books. Probably in reality there may be more, but there are currently 2 on the books safe consumption sites in the U.S. they're both located in New York City. Philadelphia attempted to build a site called Safe House, but was blocked by the federal government. Rhode Island is investigating it. A number of places across the country are looking into it. So hopefully there will be more to come. And then finally, opioid substitution treatment. So let's talk a little bit about opioid substitution treatment. And, I'm sorry. If someone wouldn't mind helping me, I seem to not be able to advance the slide here. Oh, there we go. Oh, we got it. Okay, great. So opioid substitution treatment. So opioid substitution, right? This term substitution has traditionally been a taboo term in our lexicon. Why is that? I personally think it's because of our country's uniquely puritanical roots. If you look elsewhere in the world, including Canada and various countries in Europe, people use the word opioid substitution all the time. Substitute one opioid for another opioid. Replace one opioid with another opioid. Trade one drug for another safer drug, right? These are concepts that we should not be afraid of. If we can replace the opioid that's on the street, that's an unknown, that may be adulterated with fentanyl or carfentanil or xylazine or various other derivatives that are adulterating compounds that can kill people. with another opioid that is medical or pharmaceutical grade, that is regulated by the government, that can be dosed appropriately, that we know what it is, then we should absolutely not only accept that or tolerate that, but embrace that, right? So we are not going to be afraid of the word substitution for the purposes of this discussion. Everybody on board with that? I like it. So what does opioid substitution treatment and the provision of opioid substitution treatment look like through a harm reduction lens? So it looks like lowering the barriers to accessing treatment, right, as mentioned in the SAMHSA definition. This is a photo of the REACH van, which is a van where I had the privilege of spending time during my addiction medicine fellowship at Johns Hopkins, that literally, physically, geographically goes to where the people are. So it parks at different locations in Baltimore. This one is outside of the jail, and it provides buprenorphine, which we'll talk about, in a way that's really easy for people to just walk on and get, right? So lowering the barrier to accessing treatment, geographically speaking, and then also thinking about it in kind of more of that metaphorical way, right? We want to minimize the rules or conditions that are associated with treatment. So in my primary care practice, I might have a patient with, say, serious diabetes, really poor control of their diabetes. I would really, really like them to work with a nutritionist. However, if they do not meet with a nutritionist, if they either can't access it or they decline to do so, I am not going to decline to provide them medication for their diabetes, right? So similarly, if somebody is dealing with addiction, we might say, you could really benefit from attending some meetings, joining a community of people who don't use drugs, meeting with a therapist, establishing mental health care. All of these things can benefit this individual. And yet, if we're really being ethical, and if we're really embodying a harm reduction philosophy around providing access to treatment, none of those services should be prerequisites for accessing the medication that can stop the individual from using drugs or decrease their use of drugs or prevent them from overdosing while they're still using the drugs. So we want to minimize the rules or conditions that are associated with treatment. Avoiding abrupt discontinuation of treatment, right? So there are going to be circumstances where it's not clear that the treatment is benefiting the patient. That's absolutely true. And what we want to do in those situations is address the ongoing drug use through the lens of safety, and we want to talk about how to adjust the treatment plan to better serve the patient. Sometimes that looks like being more flexible with the dosing of the medication or the formulation of the medication. Sometimes that looks like the provider, the prescriber, humbling themselves and saying, yes, traditionally, this is the maximum dose of the medication. And yet for you, you're telling me that if I give you a little bit more, you're less likely to use drugs from the street. And so maybe I need to humble myself and be a little bit more flexible about this, knowing that going up on the dose of the prescribed medication is always going to be safer than the person using something from the street, right? So sometimes it means being flexible, humbling ourselves. Other times it may mean switching from one medication to another or providing additional services on top of the medication. But what it does not look like is kicking somebody off medication because they use drugs, right? So coming back to my diabetes analogy, if I've got a patient in my primary care clinic who I know has diabetes, and I see them in the waiting room and they're eating cookies, and then they come on in to the back and we check their sugar and it's high, I am not going to cut them off of their diabetes medication in response to seeing this behavior, right? So, and I've used this analogy before in conversation with somebody from a medicated MCO plan in a conversation around dose limits and insurance coverage. Oh, I think we have a question. I'll take it in just a second. Dose limitations and insurance coverage for these life-saving medications for opioid use disorder. And the response that I got was some chuckles, and I like that because I think if we start with a place where we can start making each other laugh as we have these conversations, and that can create a way forward to open up some meaningful dialogue and change. I saw a question in the back there. Please go ahead. Yeah. Absolutely. Absolutely. So I'll repeat the question because I know you didn't have a microphone. So the question was, what do you do when the insurance company won't authorize the medication for the opioid use disorder because the insurance company doesn't like the fact that the patient is still using drugs, that they can't provide a urine drug screen that doesn't show any use of drugs from the streets. So they're saying, we're not going to cover it anymore, or we're only going to cover up to this dose, right? So I would be happy to share some resources. There's a terrific bundle of references that was developed and disseminated at the American Society of Addiction Medicine, the ASAM conference this past April. So it was developed by a team of presenters there that you can use. So when you write back, when you file your appeal to the insurance company, you can say, please see this attached compilation of references that shows why we need to be more flexible about doses, right? So yeah, I would be happy to share that with you. Let's definitely connect afterwards. Excellent question. So we talked about what harm reduction looks like in the specific setting of opioid substitution treatment and the philosophies that we want to hold as we provide this treatment, right? What is the specific treatment, right? So for anyone who is not familiar or would like to learn a little bit more about these, I'll go over them briefly. And again, I'm happy to speak more afterwards if you have specific questions about the pharmacology of the medications. So one of the big ones is buprenorphine. Right? Buprenorphine is a partial opioid agonist. So that's a fancy way of saying, you know how you go to a show and then there's an opening act, right? So imagine you have an opening act. It's not the real thing, right? It's just an opening act. It's a little bit of a teaser. But this opening act is just kind of refusing to get off the stage, right? Has anybody ever been to a show like that where the opening act is like, okay, we're ready for the real thing. Why won't you get off? So that's kind of what buprenorphine is. It's not the real thing. It is not a full opioid agonist. It does not cause overdose, except when it's combined with other things, and there's always exceptions and da-da-da. But in general, it doesn't cause overdose because it's not a full opioid agonist. And yet, it hangs on to the opioid receptors in the brain pretty tightly. It's not getting off the stage. So that means that it prevents the full opioid agonist, like the heroin or fentanyl or other opioids, from getting on board. So it's protective against overdose while not being a full opioid itself. It can be prescribed out in the community, though it does require a waiver for the provider to prescribe it. Methadone, in contrast, which has been around for considerably longer, is a full opioid agonist, like heroin and fentanyl are full opioid agonists. However, it lasts longer, so the chasing of the drug and the ups and down levels in the brain are not an issue with methadone. So that's why it's been chosen to be utilized for treatment. It cannot be prescribed out in the community, except, interestingly, for pain, it can be, but not for opioid use disorder. For opioid use disorder, it has to be dispensed at a certified opioid treatment program. So what kind of benefits do we see with these medications? So coupled together, the data for buprenorphine and methadone is really, really strong. So opioid substitution treatment, as defined as these two medications, decreases the risk of overdose by 76% at 3 months of follow-up and by 59%. So the effect is quite preserved even a year out, that we're cutting overdose deaths by more than half. We do not see these same benefits with naltrexone, which is also known as Vivitrol, or which is an opioid blocker, or opioid antagonist. We do not see these same benefits with non-medication treatment modalities. Another brand name, by the way, for buprenorphine is Suboxone or Zubsolv. So there's a couple of different formulations of it. So buprenorphine is Suboxone or Zubsolv, buprenorphine being the main ingredient, and then naltrexone is known as Revia for the oral formulation, or Vivitrol for the injection, in case those terms are more familiar. So we have really good data for opioid substitution treatment. How well are we doing at providing that treatment? We have a long way to go. So in 2019, an estimated 27.8% of people who needed treatment for opioid use disorder received any kind of medication for that opioid use disorder. And among residential treatment programs, only 29% offer opioid substitution therapy with the option to continue maintenance. So that means that while many of them may offer short-term opioid substitution for the withdrawal phase, or what's traditionally been known as the detox phase, that's a word we're moving away from because detox can be a stigmatizing term. But in any case, for that short-term phase while someone's going through withdrawal, they may offer it, but only 29% of them are giving patients the option to continue these medications, even as we see the data that these medications are associated with decreased overdoses in the long-term maintenance setting. We also see really striking racial disparities in access to medications. In a large survey among the population defined as non-Hispanic white, nearly a third had access to the medications, whereas among those defined as non-Hispanic black or multiracial, it was only a fifth, or only 15% for the Hispanic population. So we have a lot of room for growth here. And why is it that we're not where we need to be yet? So a huge reason is, thank you, right, regulatory barriers. So one is just the X waiver requirement itself. So the X waiver is the waiver I alluded to earlier that is required in order to be able to prescribe buprenorphine. Under 10% of physicians have this waiver in the country. I wasn't able to pull recent data for nurse practitioners or physician assistants. They're obviously essential components of our healthcare system. I'm just not sure that the percentage of them who have it. I will say that many physicians, and so I imagine this is the case for other level of other providers as well, many who have the waiver don't actually use the waiver. So, please go ahead. Yeah. Excellent question. So there's a long-winded historical answer to this question, and then there's sort of the SparkNotes version answer to this question, right? So the SparkNotes version answer to this question is that we culturally arrived at a place where we are very, very afraid of substitution, right? Like I was talking about earlier. And so this waiver is not required, by the way, to prescribe OxyContin or MS-Contin or any of the pain medications that contributed to us getting in this mess in the first place, right? And yet this waiver is required to be able to prescribe the medication that can help people get into recovery from these things. So I think there's a great fear of the substitution. And so there are kind of all these things that have to come around it. So the longer version of the story is that it was the 1914 Harrison Narcotics Act that disallowed the use of opioids to treat opioid addiction. Prior to that, in the aftermath of the Civil War, there were morphine clinics. People came back from fighting in the Civil War addicted to morphine. They would go to a morphine clinic, right? And they would get their morphine and then they would go about their day. And then with the Harrison Narcotics Act, it became illegal to do that. All the morphine clinics shut down. Things went underground. And it wasn't until the Nixon administration that it became legal to dispense an opioid to treat opioid addiction, that opioid being methadone. So it came attached to a lot of stipulations, including the fact that it would have to be dispensed at a certified quote-unquote methadone clinic or opioid treatment program. So with that precedent, with the advent of this different medication called buprenorphine, which works pharmacologically a little differently, as I said, it's a partial, not a full opioid agonist, it sort of had those properties that then created a little bit of political will behind making it office-based. And yet at the same time, with kind of all of those pre-existing regulations, to just go out and be able to prescribe it like any other medication just wasn't going to happen. So it ended up getting attached to a lot of other regulations and things like that. So that's the long-winded answer to your question. So there has been a push to get rid of the waiver. What's happened so far is that the pre-existing requirement of 8 hours of additional training for physicians and even longer for NPs and PAs to get the waiver, that has gone away. So you don't have to do a whole bunch of extra hours of training to get the waiver anymore. Now all you have to do is fill out a form. On the other hand, not everybody is going to be comfortable prescribing something that they've never prescribed before, particularly if the training wasn't there when they were in medical school or residency, right? So the training is now no longer required, and yet the comfort level and the feeling of facility with prescribing it is kind of not really there for the providers either. So we're sort of between a rock and a hard place a little bit. So we've got a significant underutilization, I think, that's stemming from that, as well as from the insurance coverage denials that we talked about, and then methadone having to be dispensed at a certified clinic, right? So that's something that the Biden administration is looking at, loosening some of the regulations around methadone, possibly making our model look a little bit more like that of Canada. In Canada, people can get methadone from a pharmacy. They have a model there that really expands access. It also is more kind of lenient around letting people take home their methadone and have take-home methadone doses rather than facing the stricter requirements to be able to reach that level that we have here in the US. So there's a lot of potential for change. And speaking of other countries, let's talk about some of the really innovative approaches that we see around the world, including heroin substitution therapy. Yes, you read that correctly. And also dispensaries for pharmaceutical grade fentanyl. So heroin substitution has actually been around for quite a long time around the world. It's chemically known as diamorphine or diacetylmorphine. In the UK, it can be prescribed to pretty much anybody for pain. And if it's going to be prescribed specifically for opioid use disorder, there is a special licensure requirement, which is similar to being an addiction specialist. In various other countries, it's approved for treatment refractory heroin dependence, meaning people have tried other treatments for their heroin dependence and those other treatments have not worked. So heroin is available in those circumstances in Canada, Denmark, Germany, Luxembourg, the Netherlands, and Switzerland. And research is ongoing in various countries, including Spain. So what data do we have for heroin substitution therapy? We actually have quite robust data dating back decades. So it sounds like it's innovative, but it's sort of culturally innovative in the sense that it's something new to accept, and yet the data go back a long time. So one study that comes from the 90s looked at a group of people who were offered supervised injectable heroin on top of their methadone versus a group that had to stay on methadone only. And it showed a 67% relative risk reduction in self-reported illicit heroin use. For reference, if you compare methadone to placebo, you see a 33% relative risk reduction in opioid-positive drug tests. With buprenorphine, you see a 14% reduction. We also see increased retention in treatment for heroin substitution therapy on top of methadone versus methadone only. And we would be remiss not to mention the higher risk of serious adverse events. So there is a pretty striking risk ratio there of higher adverse events in the heroin substitution group. And this can include things like seizures and, yes, overdoses. However, we do not see a higher mortality risk with heroin substitution therapy. In fact, we see a trend, and I say trend because it did not meet statistical significance, but we see a trend toward mortality protection with heroin. So that means that if trained personnel are available to administer naloxone, and we keep patients engaged in care so that they're using in proximity to the personnel, then an overdose does not necessarily have to be fatal. Conversely, if we don't provide pharmaceutical grade heroin and people are using heroin or fentanyl off the street, they don't know what's in it, they really can't control the true dose of what they're getting, and they're also not necessarily using it near someone or in proximity to someone who has naloxone, knows how to use it, and is not intoxicated at the same time, right? Then what can happen is that people are overdosing alone without help. And that's much more likely to result in a fatal outcome. So yes, higher risk of serious adverse events, but no, not a higher mortality risk with heroin substitution therapy. So the author's recommendation from the large study where this data comes from, which is a Cochrane review, is that heroin should be provided for treatment refractory opioid use disorder in clinical settings with appropriate follow-up. So that's heroin substitution therapy. Now let's take it one step further and talk about fentanyl dispensaries. Did anyone see this article in the New York Times? I think it was just last week. So it was pretty recent. So it's describing a study that's being done in Vancouver, Canada. They recently opened a pharmaceutical-grade fentanyl dispensary. So what do I mean by pharmaceutical-grade fentanyl? As I was alluding to earlier, we really don't know what's out there on the street. Dosing really can't be controlled. All sorts of other adulterants like xylazine, which is a tranquilizer for large mammals, right? Things like this. So it's sometimes known as anestesia de caballo, like a horse sedative. These kinds of things are floating out there. And when people are buying drugs off the street, they really don't know what they're getting. In contrast, fentanyl as a medicine is something that we use in the hospital all the time. To sedate patients who are on a ventilator in the ICU, for example. We know exactly what it is, we know how to dose it, and as long as it's being dosed appropriately, it is safe. So that's what we mean when we're talking about pharmaceutical-grade fentanyl. So Vancouver said, if we provide the fentanyl so that people don't have to buy some unknown off the street, then can we prevent overdoses? So the Canadian public health system is funding this. They've recently started collecting data. They're starting it at a small scale with just about 100 patients. In contrast, there have been over 1,000 overdose deaths in British Columbia from January through June of this year alone. So it's a really small scale, cautious intervention that's just begun. And the question is, does an intervention like this, does it go too far or not far enough? I'm hearing some I mean what's over here. You want to move to Canada? Okay, yeah. So it's really remarkable, right? And yet if you think about it, it's not that big of a leap from the heroin substitution therapy data, which we have going back to the 90s, right? So it seems new, and yet if you look at the data, it's not that new. It's just that change takes time. Changing hearts and minds and cultures is what takes more time than actually doing the science sometimes. So yes, I can definitely relate to that. I've had patients too who have said to me, can I move to Canada? Because don't they have a lot more options over there? And I said, I don't know if they would extend those services to somebody who's not a Canadian citizen or not. But yeah, it's a very good point. So does it go too far or not far enough? So we've got overdoses. As I think we probably all know, there were over 100,000 overdose deaths, right, in the US in the past year. It's going up all over the world. And so we want to make harm reduction interventions as readily accessible as possible. And at the same time, of course, we don't want to divert resources away from the traditional opioid substitution therapies, which do help so many people. It's unlikely that once you open up a fentanyl dispensary that all of the buprenorphine and methadone is just going to fall by the wayside, right? So I don't think that's a super legitimate fear. If you look at the budget for British Columbia, they increased spending on new treatment and recovery services in a much greater allocation than the safer supply side. There's also the question of, does opening a fentanyl dispensary reduce the perception of risk from street fentanyl, right? So the public health messaging has to be really clear that the reason we have this dispensary is because we want to give medical fentanyl that the government regulates so that you don't buy things off the street anymore, because what you buy off the street may be called fentanyl, but it's not the same fentanyl, right? So we want to be really careful to prevent reduction in the risk perception of the truly dangerous drugs that are not regulated on the streets. And also we have to acknowledge that whenever we take a risk, if something goes wrong, it can impede harm reduction efforts in the future, right? So I think it makes sense to start off cautiously, gather the data, and then expand if you're looking at it from that perspective. And then I want to leave you with some thoughts on how to define recovery, right? Because if we're talking about going ahead and giving people fentanyl, right, we're no longer talking about a pharmacologically distinct medication for opioid substitution therapy. We're talking about giving people the same thing that they were using or the thing that they were trying to use. We're just making sure it's more pure, right? So now we have to really humble ourselves in terms of how we want to define recovery. So does recovery mean avoiding drugs that are bought off the street? Maybe it does, but why? Why do we want people not to use things that they get off the street? Are we trying to stop people from getting high, right? Because this is a separate question. One thing we want to acknowledge, though, is that the vast majority of people who are using opioids every day are not getting high, right? They're using just enough to treat their own withdrawal symptoms or just to feel normal, to feel functional. They're not typically actually experiencing a rush euphoria. That usually goes away after maybe the first several months or first year of drug use. So we probably don't want to define recovery as avoidance of euphoria because it just would kind of miss the mark. And so coming back to this idea of avoiding street drug use, is the primary aim overdose and mortality prevention, right? Those two things would be consistent. We don't want people to use things that are not regulated because we don't want them to overdose. Do we want to go beyond that in our definition of recovery? Beyond overdose and mortality prevention, what about looking at improved health, physical, mental, psychological well-being, role functioning, improved relationships? And then finally, reducing stigma and shame. So people who use drugs deserve to be treated with respect and love. If we open a fentanyl dispensary in a neighborhood, and if that can normalize drug use, if people see that, people who use drugs, they don't look different than anybody else, right? Anybody, it could be your friend, it could be your coworker, it could be your family member. People use drugs. And if we can bring the drug use out into the open rather than kind of pushing it into a dark corner, and then those people experience the acceptance and love that comes from a harm reduction intervention, is that part of how we define the success of that intervention? And is the individual feeling accepted, is that part of their own recovery journey and their own recovery definition? So, some questions to ponder. And as I close, I'd like to share a little bit of information about the District Addiction Consultation Service. So we provide support to primary care and specialty prescribers in addressing the needs of patients with substance use disorders and chronic pain management. All of our services are free. So it's a free phone consultation. If you call on a Wednesday, you'll get me. And we do our best to answer your clinical questions. And we also provide education and training opportunities and assist in the identification of substance use and behavioral health resources and referrals to meet the needs of patients in your community. So that's the number there at the bottom of the screen. And here are a couple of our upcoming events. Overdose Awareness Day on August 31st, coming right up. And an opioid use disorder talk on September 27th in regards to how to integrate opioid use disorder treatment into primary care. So thank you so much for your attention, for your great questions and comments. Here are my references in tiny, tiny font, and happy to share the slides as well. And yeah, I'd welcome any additional questions or comments. Thank you again for having me.
Thank you.
Great presentation. Is there any data or research about the placement of supervised sites, and even harm reduction vending machines, like where to put them and that kind of thing?
That's a great question. That's something I'd have to look into. So yeah, vending machines that have things like syringes, as opposed to people having to physically go to a space during the hours that it's open. Yeah, that's a great question. I'm not sure what the data are. I think it would make a lot of sense. I think a lot of people are using it all hours of day and night. And so trying to make supplies as readily accessible as possible and really bringing them to where patients are physically and at all times is really important. So I would imagine that it's a really, really, it makes a lot of sense as an intervention. And as far as data, I'd be happy to look into it and get back to you.
Thank you. I was just going to offer about that question. I'm actually working on publishing a scoping review with some folks
Oh, excellent.
specifically on harm reduction vending machines. It looks at like the past like 30, 40 years
Amazing.
of literature. So I'm happy to share my information. And
Thank you so much.
yeah, absolutely.
Yeah, let's definitely try. I did my fellowship at Hopkins, so
Yeah.
let's definitely connect.
Cool.
Thank you so much.
Any more questions?
Is one over here.
I'm coming to you. Good thing I took my asthma medicine this morning.
Is there any data regarding methadone maintenance in the DMV as in terms of demand, interest, whether or not people would even consider using it? I came up doing substance abuse, as I said before, work in New York City, where in the 70s methadone was a dirty word. And now it's different, you know, and I even find it preferable to having people, you know, begin some kind of treatment with therapy as opposed to just be hanging out in the street and continuing to use. And so I'm wondering, in the district, are there enough clinics to absorb a demand? Is there a demand at all? Or is this, is there any interest in expanding?
Right. Yeah, that's a great question. So I would be happy to connect you with a colleague of mine who is the medical director for the methadone OTP that's attached to the DC jail. He knows the landscape really, really well. From what I understand from speaking with him, there definitely is a demand in the sense that buprenorphine is often not enough for people who have really, really high opioid tolerance, particularly because of A, fentanyl, and B, insurance coverage denials for higher doses of buprenorphine. So insurance and the Medicaid MCOs in particular will often cap buprenorphine at a certain dose. And so when you've got something that's already a partial opioid agonist, not a full opioid agonist, and then on top of that, there's a limit to the dose that you can prescribe, the patient is often going to find that this is just not enough and they need more opioid substitution, they need more opioid replacement. So in that sense, methadone, what you see and what I've seen clinically is that it does make a huge difference. You know, people really do feel that they're getting what they need. The only flip side of that is the barriers to accessing the methadone, like you alluded to. So one of the concerns is around limitations with take-home dispensing, because it's hard for people to get to a clinic every day, right? And at the beginning of the pandemic, in a way, it was a blessing in disguise because the regulations, the federal regulations allowed for much more liberal take-home policies at the methadone OTPs. So at that point, patients, I think, were quite happy and satisfied with it. But according to my colleague, most of the methadone OTPs in the area have reverted back to pre-pandemic policies at this point. So there's a lot of restrictions around methadone, even though pharmacologically it can offer a lot of benefit. So I think there's the tension between those two things.
If I may, one of her questions was, is the demand being met?
Yeah.
Actually, enrollment in methadone programs has decreased over the last year and a half, and they've fluctuated. Right now, they're kind of on the rise, but there's 3 funded methadone programs in DC, and those programs are not at capacity. The other thing about access is that any treatment facility that's certified by the Department of Behavioral Health should be an assessment and referral resource where a person can walk in, get an assessment, and be referred to treatment on that same day. And the methadone programs actually are open where a person can walk in, be assessed, and receive services on that same day.
Any other questions? Okay. We'll let you have the last question.
Just on the methadone questioning, is it generational?
Yeah, that's a good question. I think I would say in my clinical experience, I've treated people kind of at all ages with both buprenorphine and methadone. But I don't know specifically if we look at data on demographics, if we see a significant age difference. We do see some significant kind of racial and socioeconomic disparities for sure, where unfortunately the access to the office-based treatment of buprenorphine, which is so much more convenient, is being disproportionately provided to people of higher income levels or white as opposed to people of color. So that's definitely a huge demographic concern where we need to do a lot of work to make it more equitable.
Right. If there are no more questions, can we give Dr. Salwan a hand?
Thank you so much.
I
you.
I learned a lot. We keep talking about learning, and so I appreciate this conversation. It is now break time, a 15-minute break, and then we'll have our next session. The session that will be in here is on workplace policy. Otherwise, there are 2 other sessions going on. And again, thank you. Thank you so much. I appreciate it.